especially having worked in Canada for the better part or pretty much a full decade. Utility of osteopathy has become very, very paramount, and I know I use that terminology. Partly, I may choose not to highlight a particular commercial brand. It doesn't mean that the methods are not brilliant. There's just things that just don't sit right with me. And of course, people do own words, and if they don't like other people using their words, we have seen, not necessarily with me, but with others, even formal cease and desists of people that are positively communicating about that. But osteopathy is really a global approach that would suggest that movement of the bones, osteo, would solve all 10 systems of the body. So we don't have a lot of true osteopathy in America as it appears. Of course, you're going to find some, and you'll find them in pockets where there are very significant traditional osteopathic schools. Obviously, there's a lot more DOs than there are true osteopaths. And even though they're learning these things in their osteopathic programs, it's not quite the same, simply because a DO and an MD have all of the same privileges on how they can conduct and practice their craft, and neither are good or bad. But really, when you look at osteopathy, and in Canada, an osteopath would be very similar to what you would see as an osteopath in the UK or France. And actually, I would consider that that's what a really, really good physical therapist or chiropractor should be looking like. Now, the reality is I would probably only subscribe to osteopathic approaches for musculoskeletal issues, even though all 10 systems of the body are fair game for osteopaths or even chiropractors. Now, whether they're successful at those things or not, that's for debate, and how they're testing for these things. So that's what I kind of want to talk about. I'm far more interested in using very reliable and things that have far more overall validity as the tests, because if we do that, then you welcome interventions from all different types, even the ones that you don't care for or like, because if something gets the job done, that means there was scientific merit. Now, I think, as I've talked, and we put an Instagram post not too long ago, like, don't use the evaluation if it automatically comes with a treatment intervention. Now, if there's a test, and the only way to solve the test is to do the exercises or the manual therapies that are taught with that test, I think there's a lot wrong with that. And you're going to see that in a lot of these osteopathic approaches, among others. So that's not a limiting factor in my mind, but I want to use an evaluation that lives separate from the treatment approaches, because if I understand what you're trying to accomplish with those exercises or manual therapies, well, then I can use them against this other model where there isn't any relative bias. I think we see that in other models. And it's not that the tests don't make any sense, but for me, I would simply say, if the only way to solve the test is to do what you also want me to do and not do anything else, that's a problem. And I think that's the case with certain things that have this osteopathic history and how it's kind of shaped and then disseminated. It doesn't mean the interventions are all useless. It doesn't cut the mustard with me. I want to use the model. I actually do value the evaluation pieces, but only as a secondary approach. I'll use my evaluation approach, and then if I feel like the intervention is going to solve my problem, for instance, I will use some other model to determine if I need a wrench. And then I open the box of wrenches. But there's a whole bunch of different wrenches of different sizes. So I may need a specific wrench evaluation, but I already know that the wrench is going to solve my problem. But I can't just pick one unless I'm going to pick them all. And sometimes that's a good way to learn exercises from a new model. Just do them all regardless whether the person needs them or not. But that's really how I would look at osteopathy and really to appreciate. Now, I know in some of these courses that I've taken, there absolutely are exercises that are meant to be a part of a treatment plan for medical pathology. I have mobilization exercises for different lobes of the liver. And if I gave them to somebody, I'm not sure that you would know that they weren't just some funky, interesting looking or oddly looking thoracic mobility, given obviously the location of the liver. When we look at, let's say, those types of osteopathic approaches, whether they're for musculoskeletal solutions or medical solutions, one of the approaches, maybe how I would describe it, and if anyone is a champion of these models and you think it's different, that's okay. You can say it your way, I'm going to say it my way. If you had a doll or a puppet, and all the components of the puppet were held together by rubber bands, really decent sized rubber bands so they wouldn't break. If you pulled the arm out this way, and you pulled the arm out this way, and you were able to pull the head up a little bit, and you were able to pull the legs out, and it kind of looked the same, but everything was distracted, and maybe you had this unique ability to pull the vertebrae up, and you're just creating this relative space. Well, the suggestion would be that if you superimposed all 12 fascial lines that we know from Thomas Myers in a live person, and you follow certain rules, if you tensioned them all at the same time, only one area would actually remain relaxed. For instance, if I'm holding an imaginary rubber band, that if I pull the rubber band apart, the middle is still relaxed. So if I can set up that system of rubber bands where perhaps the psoas would be the only thing that has no tension, I can create this incredibly positive relaxation impact on an area. It would be purported to be, let's say, the psoas, if indeed I set up with the hip in relative hip extension, maybe the trunk in a little bit of side bending away, maybe that same hip with a little bit of internal rotation, because we know the psoas tendon is at the medial side. I want to say the lesser tubercle, or tuberosity. I always get confused between the hip and the shoulder. And then we run all of these upper body strategies, pack neck, tall, and then whether it's one or two arms, external rotation, elbow extension, wrist extension, finger extension. That is the rubric to kind of pull the doll apart. And if we can set up in certain positions, I think when we talk about muscles, because we know what muscles are, we kind of know they go from here to here, it makes sense. Oh, I can see why you are saying that you're stretching. I believe it's relaxation. The same thing ends, because if something happens really, really fast, you can't change the tissue. But what you can change is the nervous system's impact on the tissue, so it relaxes. You can take advantage of breathing and creating this action of different respiratory mechanisms that allow for the nervous system to acutely change. And now a lot of this is starting to sound like hocus, but that's because osteopathy goes by a different set of rules, at least how I have been exposed to it. And a lot of my exposure has literally been off-label. There's so many brilliant osteopathic trained individuals in Toronto and Canada in general, because it's a normal thing there, just given the influence from the UK. That's how I learned most of it. I've really only taken a handful of courses. In fact, some of the handouts and documents that I've gotten from my colleagues, coworkers, friends, etc., you show them to the instructors, they're like, oh my God, I've never even seen this before. So this stuff, anything that you learn now is a lot of it is different. And that's the segue into DNS is osteopathic. Even in the early courses, and sometimes you can even see a little bit of it today, there's DNS for GI issues, obviously DNS for fertility. DNS for pediatrics would in theory be something different than musculoskeletal things that we all in the training, physical therapy, chiropractic world typically get very excited about. But just given what is, and I'm much more comfortable talking about DNS as I don't know what level I'm at, but I was in Prague. I think I was like the second or third group that ever went through. I might be a certified practitioner. DNS in my mind, has explained how so many things work, even though I probably don't use those exercises exclusively. And there's certain things that are so linear that it's almost meant to exclude you from doing other things. I remember somebody telling me that you couldn't do inline half kneeling because the hips aren't centrated. I'm like, all right, that's all right, man, let's talk about football. But again, like the value of intra-abdominal pressure, the value of the first and second abdominal chains, which would be an analogy to to what I was describing with the 12 anatomy trains from Thomas Myers, if we try to leverage and acknowledge those chains of fascia, then you create this tension that creates this other thing that either relaxes or tenses. I was coached by, obviously, one of my best friends and someone who I owe a lot to this osteopathic thought process that I have, Sam Gibbs. He's like, osteopathy can become very simple. Remember, geniuses make things really, really simple. Other people start to get mad. But osteopathy is either things are just too close together or they're too far apart. Sounds a lot like mobility and stability to me. And again, the commonalities of different messages that are often challenged. Now, they're really meant to be a global starting point of thought. There's going to be times that it's easy to poke at. But if things are too close together, we have to figure out a way for that tissue or that environment to have more space. If things are too close together, that's what we're trying to do. But if things are already too far apart, aka the tissue is torn, how do we create the connective elements that bring them back together? Again, I'm really focused on the musculoskeletal components of these models. But let's say there was excess tension around an organ. I would simply just say, let's get there from the traditional tried and true medical examinations, blood work, rebound tests. Let's do CT. Let's make sure that we're looking at a liver problem. And then I don't even know that you need to only run a medical component of liver pathology and not also run in parallel some of these fascial mobilizations. And I'm just using the liver because it's kind of like wild. Like the first time you see it or when I'm learning, oh really, y'all have a stretch for the liver. But that's because I'm not trained in osteopathy. And certainly I would love to be able to see traditional measures and general health improved from those things, because it would really provide legitimacy, because I do believe that they work. I would never provide this as under the guise of being a physical therapist. I certainly want to know all those things, certainly believe all those things matter, and that even to that end, if indeed T10 is the primary innervation for the liver, well then I have no reason to think that doing something to T10 is reasonable to be part of the solution. To suggest that doing some type of manipulative or high velocity, low amplitude thrust at T10 will automatically cure the liver, that's ludicrous. How about do it and then let's run the other tests. And obviously I talk more there a little bit there sarcastically about chiropractic, but I'm not against anything. I'm against inconsistent evaluation, and I'm against methods that do not create any change. We just say you create a change, or we harp on the change that isn't one you want. Obviously, there's a lot of things that can help us feel better, but things that don't get better. And clearly, if there is a primary, and this would be osteopathy or any other model, anything that is only passive, I am a huge proponent of passive approaches. I think there's a lot of people that kind of tip the seesaw to one side, don't ever do passive. That's ridiculous. If I can get to the same result as you, but I get there faster, that means I'm better than you. So to think that we shouldn't be using these manipulative techniques, the problem is if we don't follow them up with active exercise, well then it looks like it does nothing. When in fact, these are all very, very good techniques, very, very evidence-based techniques, but whether it's manual therapy, manipulation, dry needling, anything that's passive, we need to immediately follow it up with some type of active exercise, and ideally active exercise that subscribes to progressive resistance and progressive overload. If it doesn't have overload and it's just an exercise, well then it's really not terribly different than the therapy. And again, there are models again in that space, because it doesn't go by the same rules, that would suggest that you need to do this thing all the time, or for instance your body will snap back. I don't think that's the words that these models would use, but your body will revert back to this inherent asymmetry that's not good. This is all ludicrous to me. I think people were getting amazing, amazing results before some of these models became very popular. And in fact, when you actually look at all of these models, they track back maybe even century to where some of these models really had their birth and their initial core values established. So I think it really fits into Methods are many, principles are few. And I am a huge user, as many know, of these osteopathic approaches for musculoskeletal issues. But I would not use the osteopathic evaluation model to get there. The things that I've seen are not reliable. If someone has small hands and you work with giant people like the fellow that was just here this morning, it can become very difficult to actually feel things and then develop a treatment plan off of that. I don't buy it. But it probably does speak to the power of the exercises or positions or breathing strategies or even manual therapies that people are using, because clearly they're getting results. I think we can be real focused with the keen movement evaluation of changing positions, changing the stabilization demands, eliminating joints and active versus passive. Let's land where we're going to choose a cascade of choices that target pain, that target mobility, that target stability, motor control, and then get after fitness, where there is no osteopathic approach for fitness, because if you have pathology, fitness is going to be relatively impossible to achieve. It doesn't mean you can't train hard. It just means that system is not appropriate to be delivering fitness adaptations. We kind of have to bring our head above water first. I'm really just describing how I think about things, but I used osteopathy as a little platform because it's some of the most powerful stuff that we have, and it should not be discarded. It should not be laughed at. If we're going to laugh at anything, it would be this is all you need, and you don't need anything else. And unfortunately, that's not exclusive to osteopathy. It still, to this day, the most popular stuff, continuing education, still appears to be rehab-based. Rehab professionals that are teaching these things. And it's not that it's so wrong or useless, but I'm always going to kind of filter my approach to, I'm not going to teach you how to be a bad physiotherapist in 2 days. There's plenty of seminars out there where you can do that.